So hello, everybody who has joined us today for the free international live webinar on why one hormone is not enough. This webinar is supported by an unrestricted educational grant from Gideon Richter, and I especially like to point out that Gideon Richter has had no influence on the presentations of the speakers. My name is Helena Kalner. I am the current president of the European Society of Contraception and Reproductive Health. I'm a senior consultant in obstetrics and gynecology at Danderyd Hospital in Stockholm, Sweden, and associate professor of Karolinska Institutet. And with me today as moderator, I have Manuela Farris, who will show up later on in this webinar. She's also a consultant in OBGYN and is also part of the executive committee of the European Society of Contraception and Reproductive Health. We have two prominent and well-renowned speakers with us today. It's Petra Stute from the Department of Obstetrics and Gynecology of the University Hospital in Bern, Switzerland, and also Tommaso Simoncini from Pisa, Italy. So I would like to speak shortly about our society and the benefits of becoming a member. So the ESC current membership fee is 70 euros per year. However, if you are more than 10 members in your country, you can come together as a society and become affiliated members for a 50% reduced yearly fee. The advantages of being a member include 6 free editions of the European Journal of Contraception and Reproductive Health Care, which is an online access journal for members. We also produce regular newsletters, and you have free access to our webinar, such as this one, which is of course free for everybody, but not all the webinars are. You also get a reduced Congress and event registration fee, and you can of course also become part of our board, which is a very nice thing to be, working with contraception and reproductive health worldwide. We also provide access to a forum called Doc Matter, which is a secure interactive community or forum where you can post questions or put up things for discussion within the topics of contraception and reproductive health care. Doc Matter is a benefit then of the ESC membership, and this is really a good community. If you have any current questions regarding contraception, for example, how to use a certain product, etc., there is good answers to be found there from other members. We then discuss access to reproductive healthcare services in different countries, and also access to contraceptive services and how to use contraception. But we also discuss risks with contraception and how to best educate patients and do remote consultations, etc. Now, for this webinar, if you have any questions, there is a Q&A button on your screen, and you just push that and you write down your question. You can also vote for each other's questions. You click on the thumbs up sign, and we will then choose the questions that have gotten the most votes first, because those are the ones with the highest interest. Any questions that have not been addressed during the Q&A question and answer session will then be addressed and added to the ESC website. So then over to, I think, myself, who is doing the introductory slides on this webinar. So then, why is one hormone not enough? These are my declarations of interest. As I said, this following presentation is then sponsored by Gideon Richter, but all the slides represent my opinion, and they have not been influenced by Gideon Richter. I am proud to say that I work for almost any company in especially Sweden, where I'm most active, that deal with questions of contraception and reproductive health, and also other types of healthcare for women. And I'm proud to work with any company that represents my interests and have the same ethical foundation as I do. So then, why do we need effective contraception? I think this is especially important to remember in times like these, where there are wars going on and there's a backlash in reproductive rights in some parts of the world. So if we look then at the current unintended pregnancy rate, it is actually highest in low-income countries. And as we know, of course, the intended pregnancy rate is very much connected to the abortion rates. However, the percentage or proportion of unintended pregnancies that end in abortion vary much across the world. And of course, has to do with things like ideas about how many children constitute the optimal family size. The impact of unplanned pregnancies are well known. And I really like to point out, and it is so important that we all take this message with us, that reducing access to contraception does not lead to an increase in births. However, it leads to an increase in mistimed pregnancies and births. And these mistimed pregnancies often mean that women have children before they want to. And thus, women are hampered when it comes to achieving an education. This leads to women getting worse jobs. This leads to poorer families. And young women tend to stay home more with their children, not going back to working life. This increases poverty and decreases working life participation for women. And it also leads to women getting more isolated and not participating in public life. And this, in the end, leads to a quite unsustainable society where individuals cannot reach their full extent. So we know that smaller families allow parents to invest more in each child, and the children with fewer siblings, and this is especially true then in low-resource countries, they tend to stay in school longer than those with many siblings because they are not required to stay at home to take care of their siblings. So access to contraception and use of contraception leads to a sustainable society where all individuals can contribute to their fullest extent. We cannot afford to have a large part of the population not being able to contribute to their full extent. At the same time, we have misconceptions and myths when it comes to contraception. And I think we all know what women want to. They want to feel well, they want to reach their full potential, they want to have planned and wanted pregnancies, and they want to have their desired number of children. But they also want contraception, often with a lower hormone dosage, and we will talk a bit about this, but they want it to be highly effective. There are many studies showing that effectiveness is one of the highest rated important things about contraception. And of course, women don't want to have venous thromboembolism, so they want a low risk of thrombosis. Now, if we look at the European situation, there's more and more evidence of hormone scare. So people are scared of using hormones. And these fears and misconceptions are completely irrational and not founded in evidence-based medicine. And in Sweden then, where we did our research, we found that fear of hormones was an increasing reason for not using contraception, and that it is on the rise. And there are so many misconceptions about, especially the pill, that all pills are the same. And people also feel that there's not enough knowledge among providers and users about the differences of the pills and also the side effects of the pills. So there have been several strategies then to lower the health risks of combined hormonal contraception, especially the dose of ethanol estradiol has been reduced over the years, but we are now reaching a level of ethanol estradiol where we get an increasing bleeding problems and spottings. So reducing the dose of ethanol estradiol further does not seem feasible when it comes to bleeding patterns, and also it does not seem to reduce the risk of thromboembolism enough. So then what has happened is that we have instead reverted to the natural estrogens that were originally discarded because of the bad bleeding patterns that we had in those days. But when we look today, when we combine the natural estrogens with effective and well-tolerated progestins, we can achieve good bleeding patterns. we have yet to see in large studies if the risk of venous thromboembolism is actually reduced with these formulations, but all preclinical data points in that direction. We have also started using newer progestins, and these progestins then, of course, are aimed at inducing fewer androgenic and glucocorticoid side effects in women. They are also mostly a little bit anti-androgenic and also have potentially favorable anti-mineralocorticoid effects. So that was just an introduction, and in this European Society of Contraception webinar, we will then discuss the role and importance of estrogen in combined hormonal contraception, which will be presented by Dr. Petra Stute, and then also look at the estetrol as the estrogen component in combined hormonal contraception, presented by Professor Simoncini. So then I would then very much like to introduce Professor Petra Stute, who is the Chief Physician of the Endocrinology and Reproductive Medicine Department of the Department of Obstetrics and Gynecology of the University Hospital of Bern in Switzerland. She is also an Associate Professor at the University of Bern. So please, Professor Stute, I give you the floor.
Okay, so I hope everyone can see me and hear me. Just a second. Yeah. Okay, just a second. Okay, so welcome everybody from Switzerland, and it's a great pleasure and honor to talk about the estrogen component in combined hormonal contraception. These are my disclosures, and I would like to start with a case. So let's imagine there's a 20-year-old woman presenting for contraception counseling. She has a normal menstrual cycle. Her personal and her family history are fine. She doesn't take any medication. She's normal weight. She's not smoking, and she performs competitive sports. She has some acne. She doesn't want an IUD, and she wants as little chemistry as possible. So she's actually wondering if a progestin-only pill, for example, is the perfect option for her. So let's start with my thoughts about this woman. So first of all, I think, well, she's healthy. So officially, she doesn't have any contraindication to any contraceptive methods available. Then, well, she's doing competitive sports, so I would imagine that cycle control is very important to her, and she probably wants to have a contraceptive method which does not have an impact on her body weight. She has some acne. Well, I think it would be nice to get rid of that. And I'm wondering if she's at risk of red S because of this competitive sports she's performing. So the topic bone health might be important. And finally, this chemistry fear. Well, I think that needs some discussion. Okay, let's start with talking to her about the several contraceptive methods that are available. And of course, you all know them. So we have the non-hormonal contraception options, and we have hormonal contraceptives. And within the group of hormonal contraceptives, we have the combined estrogen-progestin combinations, and we have progestin-only products. Let's think first about how these hormonal contraceptives work. Well, the most important component for contraception is the progestin component, because the progestin reduces LH and thus suppresses ovulation. And at the same time, the progestin component thickens the cervical mucus, and thus the sperm penetration through the mucus is impaired. The estrogen component is important because the estrogens induce progesterone receptor expression within the endometrium, and thus the risk for breakthrough bleedings is reduced. At the same time, the estrogens reduce FSH, and this is why the development of a dominant follicle is impaired or stopped. Okay, let's have a closer look at the estrogens. So the estrogens, estriol and estradiol, were discovered in the 1930s. And then 10 years later, ethinyl estradiol was developed. And then it took about 20 years until the next natural estrogen was discovered in Sweden, which is estetrol. So ethinyl estradiol until today is the mostly used as estrogen, which used in hormonal contraceptions. Ethinyl estradiol is a synthetic estrogen, and because it has an ethinyl group at C17, its metabolization to estradiol and to estrone is not possible. Then we have the natural estrogens like estradiol. So estradiol is the natural estrogen produced in the ovaries. And then, as already said, we have the more or less new one, the estetrol, which was discovered in the 1960s, which is produced by the fetal liver. And later on, Tommaso will tell us much more about this new estrogen. First of all, I would like to focus on the topic cycle control, because I'm pretty sure that a woman wants to have a regular cycle and does not want to have any intermenstrual bleeding. So in our case, our woman suggested a progestin-only contraception. So the first question or the first topic to talk with her will be cycle control with progestin-only pills. And there's a study which was published 3 years ago, which compared the bleeding profile of the progestin-only pill drospirenone to the progestin-only pill desogestrel. And women in this study used one POP compared to the other for 9 cycles. So let's have a look at the results addressing cycle control. So in this study, the primary endpoint was the proportion of women with unplanned bleeding or spotting. So let's have a look at how many women had unplanned bleeding and spotting after 9 cycles of using drospirenone or desogestrel respectively. So we see the numbers that roughly 44% of women using drospirenone only had unplanned bleeding or spotting after 9 cycles using this progestin-only pill. If we now look at the column on the right side, we see that women using desogestrel, that in this group, 45% of women reported unplanned bleeding and spotting after 9 cycles of use. One of the secondary endpoints was the number of unplanned bleeding and spotting days. Now we focus again on the number of days women reported unscheduled bleeding and spotting during the 9 cycles. And we can see for drospirenone that the average number of unplanned bleeding and spotting days was 21.5 days. In the desogestrel group, this number was even higher. So here we have on average 35 days of unplanned bleeding and spotting during 9 cycles of use. So now our patient might be already convinced that a progestin-only pill is not a very good idea, especially if she's a competitive sportswoman and she doesn't need any bleeding unexpectedly when she is on a competition, for example. So the next question then is, how is cycle control if we compare combined oral contraceptives, COC, to progestin-only pills? And herefore, I would like to introduce to you the so-called content study. This is a prospective, non-interventional observational study in which Clara was compared to a progestin-only pill. Women were followed for 1 year, and one of the endpoints of the study was again the bleeding profile. And here is one of the results. In this graphic, you can see how the proportion of women with a regular menstrual cycle changes during this 1 year of treatment. We see that at the beginning in both groups with Clara and as well with the progestin-only pill, about 85% of women had a regular menstrual cycle. Then they started with Clara or with the progestin-only pill, and we see that the number of women reporting a regular menstrual cycle is decreasing. But still, though the number of women with a regular menstrual cycle using Clara is higher at the end of the study, with roughly 67%, compared to about 23% with a progestin-only pill. So now you might wonder, what has happened to the other women if they do not have a regular menstrual cycle anymore? Well, there are some women which indeed have an absent withdrawal bleeding from time to time. This is true for about 1/4 of women using Clara. And this is also true for about 1/3 of women using a progestin-only pill. There will also be some women reporting amenorrhea. And this is true for about 8% in women using Clara, whereas about 43% in women using progestin-only pills will report amenorrhea. And the number of unscheduled bleeding is slightly decreasing in the study with Clara compared to the progestin-only pill, where it's slightly increasing. Okay, let's have a look at the other topic, because we are pretty sure that women, especially if they are working out, but I think that's true for all the women, they don't want to put on weight if they start a new hormonal contraception. So let's have a look first what we know from the literature about the impact of progestin-only contraception on body weight. So there's a Cochrane review from 2016 in which 22 studies were included with more than 11,000 women. And those women used different kind of progestin-only contraceptions. And the authors of this study found that there's limited evidence of a change in weight or body composition with the use of progestin-only pills. And mean weight gain at 6 or 12 months was reported to be less than 2 kilos for most studies. Now we switch to the combined oral contraceptions and their impact on body weight. This is again a Cochrane review analysis from 2014. In this study, they included 49 trials, and they had different kind of COCs that were compared to each other or to placebo or to controls. And they found that in those trials where COCs were compared to placebo or to controls, that combined oral contraceptives did not increase body weight. And when they compared the different COCs to each other, they also came to the conclusion that most comparisons of different COCs did not show substantial differences in body weight. Now to acne. You remember our patient has some kind of acne, so she would of course like to get rid of that. So happily, there's another Cochrane analysis addressing the impact of combined oral contraceptives on acne. In this analysis, 31 randomized controlled trials were included with more than 12,000 women that were treated with COCs for 3 up to 13 months. No surprise, most oral contraceptives that were compared to placebo showed a significant improvement of acne by COCs. Then the authors were also possible to do some head-to-head comparisons, and they found, probably also no surprise, that anti-androgenic COCs are even more effective than just regular COCs in the context of acne. But overall, the authors concluded that COCs should be considered with women with acne who also want an oral contraception. Now we turn to the next topic, and this is bone health. So first of all, we have to ask ourselves, what happens to our bone if we have regular menstrual cycles? And now we start using an hormonal contraception. And I would like to focus first on the left side, because here you can see the pros of hormonal contraceptions and on bone health. So here we have some convincing, or a lot of convincing data showing that in almost 13,000 women, it was found that there's a significant reduction of fracture risk with the use of combined oral contraception. And this effect was strongest in the age groups of 18 to 25 and 26 to 35, especially if those women used their hormonal contraception for more than 1 year. And additionally, the significant decreased fracture risk was even further reduced with longer duration of COC use. But as always, we have some open questions. So one open question addresses the dosage of ethanyl estradiol in a combined oral contraception. And there are some concerns that if the dosage is very low, less than 20 microgram of ethanyl estradiol, that this might have a negative impact on bone mineral density. The second open question addresses the age at initiation of the combined oral contraception, because there are some hints that if a woman starts oral contraceptives during their adolescence, that maybe her BMD, body mass, bone mineral density, will be a little bit lower than compared to healthy controls. But still, if now taking all these different studies together, the international guidelines say that there's no evidence of an effect of COCs on fracture risk. However, there are only cohort and case studies and no RCTs with sufficient observation duration, and only in specific subgroups an increased fracture risk was observed. And at present, it is not possible to answer the question whether women using combined oral contraceptives before reaching peak bone mass may have a negative impact or increased risk for fractures later in life. But now in our situation, you remember we had a very sportive and active woman. So we might be a little bit concerned that if she's working out so much that maybe she will develop something called RED-S. RED-S stands for impairment of physiological functions due to relative energy deficiency. And some of you will remember the term female athlete triad, which also addresses this topic, but actually is only associating energy deficiency with menstrual cycle dysfunction and bone health problems. And the new term RED-S, you can see this in this graph here, addresses all different kinds of effects energy deficiency may have on organs or other symptoms. And unfortunately, we do not know if there is a cutoff level under which cycle disruption or amenorrhea will occur and thus have a negative impact on bone health. And now let's have a short look at other benefits COCs may have. And you see this is an arrow or a timeline which was already published more than 10 years ago. And you can see that we have different benefits that were observed over the years or decades. And probably all of you are very much aware that combined oral contraceptives have a benefit for women suffering from premenstrual syndrome or premenstrual dysphoric disorder. And there's a meta-analysis that was published last year showing that indeed combined oral contraceptives were more effective than placebo in treating overall premenstrual symptoms. And this is why international guidelines also recommend that combined oral contraceptives, especially in a long cycle, may be a treatment option for women suffering from PMS, and if especially for women suffering from a PMDD, combined contraception with drospirenone may be a treatment option as far as there are no contraindications. Now let's switch to sexual function. And I'm pretty sure a lot of women starting a new contraceptive method are very much afraid that this contraceptive method may have an impact on her sexual function and libido. And yes, we know that hormonal contraceptives indeed have an impact on hormone levels because they decrease free testosterone and increase SHBG. But it's not really clear if this change in hormonal serum levels induced by COCs really has an impact on libido, because we know sexual function in women has maybe impacted by a lot of different factors, and not only by the question, am I taking a contraceptive pill or not? So most studies show that indeed most women do not have to expect a change in libido as a result of now starting combined oral contraceptives. Actually, there's a minority, 15 to 20% each, that may experience an improvement or maybe a worsening of sexual desire. But you can see improvement and worsening is the same amount of women that will report this. And there's no clear correlation between a particular pill composition and testosterone, SHBG levels, and her libido. So this means for the practice that we have to inform the woman that she might experience a change in her sexual function, but it's a rare case. Now, one of the first discoveries, apart from knowing that COC prevents pregnancies, was in the 60s, that it's also having a good impact on menstrual cycle problems like heavy menstrual bleeding. I don't want to focus too much on this because this is so very well known, and a lot of international guidelines do recommend combined oral contraceptives as one of the first-line therapies for heavy menstrual bleeding. One of the biggest fears in women is that if they start any kind of hormones, this might increase her cancer risk. And this is why it's so important to inform a woman about the fact that combined oral contraceptives are actually reducing endometrial cancer risk. And this is also true for the ovarian cancer risk. And most importantly, the risk reducing effect for ovarian cancer is even observable up to 30 years after discontinuation. So we really have a long sustaining effect. And also combined oral contraceptives are associated with a risk reduction for colon cancer. So now you might wonder, okay, this is a fantastic treatment. So are there some downsides? And of course they are. And the downsides are specifically the venous thromboembolism risk. So the VTE risk with combined oral contraceptives is mainly due to the dose and also of the estrogenicity of the combined product. And this arrow you can see here on the slide shows it very nicely. So you can see that the combination of estetrol and drospirenone is more or less in the middle. And now we turn to the right side and we see that here the total estrogenicity is increasing, and thus the risk also for side effects or risks like venous thromboembolism. So we turn to the right and we see that the combination of ethinylestradiol and levonorgestrel is head-to-head with Clara and also with Zoeli. And then we turn to the right side even more, and now we see the combination, the combined products ethinylestradiol with other mostly anti-androgenic estrogens. So in absolute numbers, this means the following. If we have a look at the first line of the table, we see the reference. The reference is the number of venous thromboembolism in women that are not using any hormonal contraceptions. And here we see that the baseline risk is about 2 venous thromboembolisms per 10,000 women per year. Now we turn to the lower part of this table, and we can see that in the ENA score study, Clara was compared to levonorgestrel with ethinylestradiol. So we can see here that in Clara, in women using Clara, there were 7 venous thromboembolism events per 10,000 women per year, compared to 9.9 thromboembolic events per 10,000 women per year. So looking at this from the statistical point of view, there's no significant difference between Clara and between LNG and ethinylestradiol. Then we have the PRO-E2 study. They compared Zoeli to ethinylestradiol with LNG. Again, the numbers of thromboembolic events was not significantly different between Zoeli and LNG and combined with ethinyl estradiol. So here we have some reassurance that indeed Clara and also Zoeli using bioidentical estrogens seem to be a good solution. And for drospirenone combined with estetrol, that's Tommaso who's going to present to you those results. Now I come back to the last argument our patient provided. She wants to take as little chemistry as possible. And I'm pretty sure that's a topic you will also hear a lot in your consultation. So actually I was looking around and I found a study from the Royal Society of Chemistry in the UK that published a document in 2015. It was a survey and they assessed the public attitudes to chemistry. So I would like to share with you for me the most important parts. So first of all, which associations are around with the term chemicals? So some say it's a substance that is synthetic or man-made. It's a substance that is potentially toxic or harmful, or that may have a negative impact on the environment or human health. And then also some examples were given, like artificial preservatives and additives to food, beauty treatments such as Botox, manufactured poisons or chemical weapons, substances requiring hazard labeling on packaging such as house cleaning products. And then the authors tried to find out if there are certain groups of people that have a certain attitude and knowledge about chemicals. So they put together, first of all, the attitude of people saying all chemicals are dangerous and harmful. And then you can see on the X line, it was possible to disagree and agree to a certain degree. And then on the other hand, they asked participants if they feel confident to talk about chemistry. And again, people could answer there was a range between disagree and agree to this statement. And then they identified 5 groups. The first one is the detached from chemistry group. This is the smallest group. So these people have a lack of interest in chemistry and science in general, and they do not feel confident to talk about chemistry, and they are more or less quite less educated. Then we have those interested in chemistry, and they have positive attitudes towards chemistry, and they are confident about talking about chemistry, and they are well educated. Then we have those that are neutral about chemistry. So they appreciate the societal benefits of chemistry, consider themselves less informed, and they are slightly less well educated. And then we have the suspicious group. So they are suspicious of chemistry. This is 20% of the whole sample. They don't see a positive impact of chemistry on their well-being, and they are quite well informed about chemistry actually, and they have a preference for natural products. And finally, we have the biggest group, 24%, receptive to chemistry. So they believe that chemistry has a very positive impact on well-being, but this is the group which is the least confident to talk about it. So I was actually wondering, so shall we focus on the 80% but the suspicious group, because they probably just need some counseling and education and then everything is fine? Or shall we focus in our work on the suspicious group, because they have the loudest voices, but it's probably very hard to convince them. So I'm still not sure where it's worth to focus on most. And this is why I come now to the conclusion. So there are many health benefits associated with the use of combined oral contraceptives. The health benefits of estrogens in COCs largely outweigh their risks. And there's some interest, a lot of interest actually, in the development of new contraceptives, which you will see in the next presentation. And the goal is to be satisfied with this new contraceptive and to have an improved tolerance, a good cycle control, and of course, a fewer or less serious adverse events. So the combined oral contraception may be the best contraception for women that are healthy and during their reproductive age. And somehow, I'm pretty sure we need to improve our education about chemistry and chemicals. Thank you very much.
So thank you for that very convincing and informative presentation, Professor Stute. Very impressed with the last slides about the chemistry and who we should really be talking about, and about what. We need more evidence on that. So I would like to introduce our final speaker, Professor Tommaso Simoncini from the University of Pisa. Professor Simoncini is Professor of Obstetrics and Gynecology at the Department of Clinical and Experimental Medicine of the University of Pisa, and also head of the OBGYN division. He has a very impressive CV, with being president of many prominent organizations, and also being associate editor of many of our prestigious journals. Please, Professor Simoncini.
Thank you very much for your very kind introduction. Let me try and share my slides. That should be hopefully on right now. I listened to the beautiful presentation by Professor Stute that I think has given a very nice introduction to my topic. So things will hopefully be quite easy. So my task today is to talk about estetrol, this new estrogen, and why it differs and how it differs from the previously available estrogens, and how it makes the contraceptive containing estetrol and drospirenone different from the previously available ones. So these are my disclosures. Let me move straight ahead towards this estradiol. So estradiol is not a very new molecule, because it was discovered in 1965 by Professor Egon von Dix-Falusi. Professor Dix-Falusi was working at the time at the Karolinska Institute in Stockholm, and he was the one who was able to identify and isolate this peculiar estrogen while he was performing studies on placental products that could mark fetal well-being, along with another prominent investigator in the United States, Elio Golpide. And later on, this very important estrogen has been, I wouldn't say forgotten, but left at the side for many years, up to the time when Professor Harry Crowley Manning thought that it was going to be a very nice molecule for clinical applications, for the reasons that I will try to explain later on. So he was actually instrumental in developing the early stages of the clinical development, doing a lot of research at the time. And then there was another major actor in the clinical development of this compound, who has been Professor Jean-Michel Fouadard, who has done a lot of studies, particularly for the development of estradiol as a contraceptive. So these are the key persons in the history of this very interesting molecule, which I am introducing with this slide. So this is a natural estrogen because it's produced by us. And when I say by us, it's because it's actually produced by both male and females when we are in a fetal life. Because it's the fetal liver who produces this estrogen via a conversion of estriol coming from the placenta. It crosses the placenta, so it enters the maternal circulation as well. It increases a lot during pregnancy, having a peak at term pregnancy. It can be recognized from the 9th week of pregnancy. And it's interesting that since it's synthesized by the fetus, the concentrations within the fetus are much higher than in the mother. And this is, I think, very important. A fetus synthesizes about 50 to 60 milligrams every day during a fetal life. When you compare it to the doses that are found during in the contraceptive that we are talking about, this I think is very interesting. So estetrol has been identified with this acronym NEST, native estrogen with selective tissue activity. Why is that? Because it's not really acting like estradiol, I'm sorry, so like traditional estrogen, but it's not actually working as a selective estrogen receptor modulator either. It has a high selectivity for estrogen receptors and a moderate affinity for estrogen receptor alpha when compared to estradiol or ethinyl estradiol. But the affinity for the two subtypes of the receptors, ER alpha and ER beta, is different. So it prefers ER alpha. It has a higher affinity for ER alpha than for ER beta. It has a mixed agonist and antagonistic activities on nuclear and membrane receptors, particularly while the nuclear actions seem to be more similar to the one that are elicited by estrogens, normal estrogens. On the membrane, there are settings where it antagonizes or actually activates the rapid signaling coming from the membrane. So it is a very peculiar set of activities which justifies this acronym NEST. From a chemical standpoint, estetrol differs from estrone, estradiol, and estriol because it has a fourth hydroxyl group, which, as you can see in the slide, makes it more polar because the negative charges are polarized on one side of the backbone, on the estrogenic backbone. And it provides also a very long half-life compared to, for instance, 17-beta estradiol, to a quite pretty much twice longer half-life. So how does this compare in terms of binding activity? This is very important in order to understand the differences in biological effects. So these chains, color chains, depict the shape of the ligand binding domain of the estrogen receptor alpha once it is bound by estradiol, by estriol, and by estetrol. And you can see that the shape of the receptor is quite similar, but not identical. And the reason for this is because of the different steric hindrance and different polarity I discussed in the previous slide. In estetrol, a part of the ligand binding domain, for instance, the helix 12, is dislocated in a slightly different manner. And this is not just a curiosity, because it's because of these changes in the shape of the receptor that the receptor decides with which co-activator and co-repressor to interact within the cells, and therefore how to enact signal transduction. For instance, this you can see from the paper from Jean-Michel Podal's group from Anabo, a very nice manuscript describing the differences, for instance, in animals on the endometrium, which is depicted in these slides in terms of gene expression in when you use estradiol or estetrol to treat. You can see that there's a lot of green, a lot of red, which means genes that are activated or repressed when the animal is exposed to estradiol or estetrol. But when you look at the same results in terms of clusters, so genes that are similarly induced by estradiol and estetrol, there's a number of genes where the two estrogens do exactly the same effects. Those are the bars in the upper graph. But there's also two different clusters, cluster 2 and cluster 3, with the genes that are actually more upregulated by estradiol and genes that are more downregulated by estetrol. So not all the genes are regulated in the same way by estradiol and estetrol to support the view that I showed you before. So estetrol is not a traditional estrogen to this extent. And when we try to depict the multiple, very complex number of things that we know about how estrogen affect the female body, tissues, the receptors, the cell types, we have a broad understanding now. It's not complete, but it's broad, and the understanding of how estrogen act on a woman's body. When we try and describe what we know about estetrol, we have a number of observations. Of course, the number of information we have is much smaller because this is a much younger molecule in terms of clinical and preclinical development and research. But we know that there are some areas like the brain or the uterus, the bone, the vascular tissues, where more or less estetrol and estradiol do act similarly, providing effects that are comparable in terms of the major functions of these structures and organs. But there's also areas like the ovaries or the breast where this is not the same. For instance, estetrol works very differently compared to estradiol on breast cells and breast cancer cells. So this is also very important because while we investigate, we are understanding better and better why estetrol differs from other estrogens, particularly 17-beta estradiol. So let me dwell a little bit on the pharmacological characteristics because as Professor Cullen-Benning noticed immediately due to his background to this extent, the very long half-life and the absence of any conversion into other estrogens like estriol and estradiol make this compound very interesting in terms of pharmacological application because it's very useful that it can be administered once a day because it covers 24 hours, and having no metabolism to other compounds, what you get into the circulation will stay as is. So it makes it predictable in terms of effects. Plus, there's another thing that is very important, and we will discuss that later on in the presentation, because estradiol doesn't bind significantly to sex hormone binding globulin. And this is a big difference compared to estradiol, because whatever gets into the circulation is free to act. So it's not bound by this protein. It's very bioavailable in terms of oral bioavailability, so it's easily absorbed, and it's very predictable how much it will get into the circulation based on the dose that is taken every day. Plus, interesting thing, it's mainly excreted via the urinary route, not by the liver, or less by the liver, which makes also a very big difference in the setting compared to how estrogens other estrogens are metabolized. And it's inactivated by glucuronidation and sulfation. It doesn't inhibit the major cytochrome P450 enzymes, which you know is one of the reasons why some contraceptives containing estrogens or ethinyl estradiol may interfere with other drugs, other treatments, and which is very important in terms of usability and safety. So from a physiological standpoint, how does this estrogen work? So estetrol has a significant anti-gonadotropic action, which means that it can collaborate effectively as estradiol or ethinyl estradiol with the progestin to which it is associated in suppressing the synthesis of LH and FSH, which of course is very important in terms of contraceptive efficacy. It has a limited impact on coagulation factors and on the lipid profile because of its lower effects on the liver, which is very important, and I will discuss a little bit about coagulation later on. It's not going to impact transport protein, so it's not just that it doesn't bind to SHBG, it doesn't also induce significantly SHBG, which is very important in terms of sexual life because of the ability of SHBG when it grows in the circulation to bind circulating androgens, And it also stimulates endometrial proliferation, which is also very important because as Professor Stute said, one of the main applications or the utilities of estrogens in combined hormonal contraceptives is to stimulate a little bit the endometrial mucosa to grow, so to avoid unwanted spotting or bleeding because of too much atrophy induced by progestins. So this slide kind of summarizes the pharmacokinetic profile among the different estrogens. You can see that estetrol has studied in the combination with drospirenone compared to estradiol associated to normegestrol acetate or ethinyl estradiol combined to drospirenone. The bioavailability is higher with estetrol. There's no binding to SHBG, while there's a significant binding to SHBG with estradiol and ethylene estradiol. There's no metabolization and no metabolization by cytochrome P450 enzymes with estetrol, while there's the opposite for E2 and ethylene estradiol. And the elimination time, so the half-life, is much longer, 24 hours more or less, as compared to less than 4 hours with estradiol. So just to summarize. So let me talk a little bit about VTE risk. Professor Stute has mentioned that extensively. There's an increased risk of thromboembolic events with the use of combined hormonal contraceptives. This is the main pitfall, as Petra has said, with these therapies. And I won't dwell on the numbers because Petra has shown very clearly what are the differences based on the amounts of estrogen and type of progestin associated with combined hormonal contraceptives. Anyhow, we do know that the number of VTE events in young women using combined hormonal contraceptives is a small risk, so it's a rare event. But nonetheless, it's a safety concern. So we do know, and Petra has said, so sorry if I repeat a little bit, but it's just to reinforce the concept that one of the reasons why the VTE risk, or one of the factors that drives the VTE risk is actually the dose of estrogen. So the higher the amount of estrogens, whatever the estrogen in the combined hormonal contraceptive you have, the higher the risk of having a VTE event. But also the type of estrogen is important. And so far, I think that a fair, convincing evidence has been accrued that combined hormonal contraceptives containing estradiol, natural estradiol, do carry a lower risk of VTE as compared to any combined hormonal contraceptive containing ethinyl estradiol. So the strategies to lower the health risk of combined hormonal contraceptives, for instance, in terms of VTE, are lowering the dose of estrogens in combined hormonal contraceptives and using natural 17-beta estradiol, based on what I said in the previous slides. This is the coagulation cascade. You know this well, well, we think we know it well. We've all studied it, this coagulation cascade as a nightmare during our medical studies. But anyhow, there's two main ways to activate the coagulation cascade: the intrinsic pathway and the extrinsic pathway that depend on different type of events. What is most important is that there's a number of inhibitors of coagulation. For instance, active protein C, which is very important because it blocks the conversion, the activation of factor 8 and factor 5, which are the main driver and effectors of the intrinsic pathway. There's the tissue factor pathway inhibitor that actually works as an inhibitor of the extrinsic pathway, which is more associated with trauma, and antithrombin, which blocks the final effector, which is the transformation of factor 10A into thrombin, driving thrombin activation. So whatever these inhibitors and activators, however they are, they can be modulated and changed by the administration of estrogens. And this is the results published by Professor Dufil in Contraception 2 years ago, where the use of 3 different contraceptives, one in light blue containing estetrol and drospirenone, with 2 other comparators, one containing ethylene estradiol and levonorgestrone, and the other one containing ethylene estradiol and drospirenone. Now, if you look at the effects to these biochemical markers of activation of coagulation, if you look at the procoagulant factors on the left part of the slide, the induction of things that activate coagulation or help activating coagulation, like fibrinogen, prothrombin, factor 7, factor 8, is much lower with the estetrol containing contraceptive compared to the other ones. And the amount of anticoagulant factors that can be reduced by the exposure to contraceptives, again, is less decreased by the estetrol containing combined hormonal contraceptive. Very important, particularly protein S activity, antithrombin, and protein C. you also have to look at the fibrinolytic factors, where again the impact of the estetrol containing contraceptive is less than the one induced by the ethinyl estradiol containing contraceptives. And this is also found in the functional assays and the coagulation markers. You see on the right part of the slide. So normalized activated protein C sensitivity ratio, which depicts as a whole the activation of the coagulation cascade. You have a lower activation with estetrol containing contraceptive. And also the coagulation markers like D-dimer and prothrombin factor 1, fragment 1+2 is also much less activated by these contraceptive. And it's curious to notice that this goes exactly in parallel with the amount of activation of SHBG, which you know is also a marker of the estrogenicity of contraceptives. So it seems to be correlated really to the type of estrogen and to its liver effect. So this is another study showing exactly the same, but by looking just to normalized activated protein C sensitivity ratio, which is the most important, as I said before, biochemical marker of the risk of VTE. And you see again that with the same type of comparison, the estetrol containing contraceptive induces a much lower increase in these biochemical markers. And is that important? Yes, it might be, because as Petra has said, we don't have really too many data because of the novelty of this combination on the market. Therefore, its clinical use really dates back to an amount of time that doesn't allow to accrue real events, even real life observation. But if one uses the APC resistance marker to predict VTE events, the amount that is activated by estetrol as contained in the contraceptive that we are talking about today is predictably much lower than with any other contraceptive, those with ethinyl estradiol, but also compared to those containing natural estradiol. So there is a rationale to think that this combination with estetrol might really drive a lower risk of VTE. Of course, this will need to be established by real studies and by the accrual of real numbers. So to summarize this part, the choice of estrogen matters. And if you use estradiol or estradiol valerate in combined hormonal contraceptives, this appears to lighten, to reduce the risk of VTE compared to ethinyl estradiol. The effect of combined hormonal contraceptives on hemostasis depends on the type of estrogen, their dose, and also their association with the progestin. And I will discuss this in the next 2-3 slides. And of course, it's not yet known how the risk with estetrol and drospirenone compares to these other lower risk products. But looking at the biochemical markers, there might be a possibility that the risk with this combination is even lower. We will see. So I said that there are strategies to lower the health risk of combined hormonal contraceptives, and changing or reducing the dose of the estrogen is a strategy. Also, choosing a progestin that is endowed with fewer androgenic activity or glucocorticoid effects, or actually having anti-androgenic and eventually also anti-mineralocorticoid effects, is thought to be, by the epidemiological data, one of the strategies that could drive a lower risk of VTE. And since this contraceptive is actually associated, it's made of a combination of estetrol that I have discussed so far with a very specific progestin, drospirenone. Drospirenone is actually a powerful anti-mineralocorticoid progestin. So it binds to the mineralocorticoid receptor by blocking it, and it has also prominent anti-androgenic effects. So it looks like this combination is really made in the right way to do whatever is possible to decrease the risk of VTE based on what we know so far on VTE risk and its link to combined hormonal contraceptives. So the combination of estetrol and drospirenone has showed so far limited effects on the hemostasis parameters in clinical studies. We've seen those data in the graphs. It's not yet known how the risk of ET with combined hormonal contraceptives containing E4 and drospirenone compares with the risk of with low dose levonorgestrel containing combined hormonal contraceptives and others. So this, for the sake of honesty, we don't have this data. But the effects on hemostasis parameters provides indication that E4 and drospirenone may be associated with a similar or even lesser likelihood to cause PET compared to 18-estradiol and levonorgestrel or other progestins. So to conclude, estetrol is a naturally occurring estrogen with selective modulatory activities on estrogen receptor, which has been indicated as NEST. E4 has a minimal impact on coagulation and lipids. E4 drospirenone as a combination makes an effective contraceptive agent with a number of potential advantages over previously available 18-estradiol or estradiol containing combined hormonal contraceptives. Some of these advantages I have discussed during the presentation. So thank you very much for listening to my presentation. Back to our chairman or chair lady, and I will stop sharing the screen. I'll be happy to take questions.
Okay, thank you, Professor Simoncini. And we are happy to open the question and answer session. There is a question if estetrol can be manufactured or it must be derived from biology. I think it's for you, Professor Simoncini.
I don't know exactly what the question means in terms of manufacturing or derived. So it can be manufactured, it can be synthesized. I believe it is synthesized from a natural source, so from plants, by chemical modifications. So it's not extracted from fetuses, of course. So don't be worried about that. But there's a very strict and well-designed chemical manufacturing process to produce in high amounts estetrol that has been developed by the industry a few years ago now. Yes.
I wanted to pose a question to Professor Petra Stute. Isn't that true that we should, every single time we have a contact with our patient, that we should talk about all the benefit, even protecting from cancer and all the other benefit, not just saying that that's for contraception and to protect you just from unintended pregnancy?
Yes, I think in the perfect world where we have enough time for counseling, of course, we should counsel on all the benefits combined oral contraception has. And I'm pretty sure it depends on in which country you're working. You have different amounts of times for consultation. And then probably sometimes the focus, unfortunately, is more on all the risks. So you are afraid that you miss a risk you could counsel the patient on, because otherwise, if she has the risk, you get sued. So I guess that's all on our mind all the time. And then we forget about the benefits.
I don't know if Professor Kalner has a question to pose.
I thought that question about the cycle days was very good from Indu Prabhakar. How can we define cycle day 1 and 9 when she is on a progesterone only pill?
So it's not cycle day, it's cycle. So this means in this study where they compared drospirenone alone to desogestrel, the women had pills for 9 cycles, so 9 months. So they had to take one pill package after the other one. So it's cycle 9 means they have already taken 9 months of this product.
Thank you for that. Helena, do you have any personal?
No, but I can ask a question for Professor Simoncini, because this is a question that often comes. So who are the patients that are most likely to benefit from an estetrol containing combined hormonal contraceptive pill? Which group of patients?
Right, thank you for the question. And I think it's there might be a lot of different answers. So if one looks at the promise, let's call it a promise of less risk of having high lipids or having a VT event, then any patient would be benefiting from these combined hormonal contraceptive compared to the previously available. Is there any specific group where this combination is of advantage? Of course, and this also needs to be looked at. All those patients that tend to have problems because of induction of SHBG, for instance, low libido, might benefit because here we're not inducing SHBG and we're not actually binding with the estrogen to SHBG. So it might be a set of women where this could be of advantage. Those women that suffer prominently by water retention symptoms, which seem to be less induced by estetrol because of its lower liver effect. So women with bloating before the menstrual cycle or even with premenstrual symptoms might benefit from using this combination. There's also a reason to think that also very young patients, particularly peripubertal or postpubertal patients needing an hormonal contraceptive in the phase, as Professor Stute has said, when they are building their peak bone mass, they might do better with an estetrol containing contraceptive rather than with an estradiol. But this has not been studied yet. So it's just speculation based on the preclinical data that we have on bone effects by estetrol. So there are different types of clinical scenarios where it might be of help in comparison to other combined hormonal contraceptives.
So connecting to this answer first, there is Maya Banovich who is asking which patients should not be offered this combination.
Can I say something then, Petra?
Yeah, please.
I'm sure.
Go ahead.
Yeah.
Just,
okay.
The consequence of your answer.
No. I think that should not be offered. Of course, any patient that has a contraindication to the use of estrogens should also be considered a patient that has a contraindication to the use of estetrol. So these are all the patients with previous VT events or inherited thrombophilic mutations. These should not receive oral estrogens anyhow. So we don't know whether estetrol is so nice to coagulation that can be offered, that could be offered also to these patients. Let's wait a little bit to consider that. To that extent, should be considered similarly. But I think that there's also clinical groups where it's very fair to think about the indication of other estrogens. So for instance, ethinyl estradiol. So if I have to think about a patient like a PCOS patients with hyperandrogenic symptoms, I do want to have their, an estrogen like ethinyl estradiol inducing SHBG, blocking effectively the production of androgens by the ovary is probably more appropriate in terms of clinical efficacy as compared to a milder estrogen as estetrol or even natural 17-beta estradiol or estradiol valerate. So we should remember that there is a role for each estrogen that we have available on the market so far. And it's good to have many. But Petra, you may want to add something.
Yes, so the first patient group, or the patient group that came to my mind first is the women with red S. So if someone is an athlete, elite, sportive woman, and she doesn't have a menstrual cycle, so she's amenorrheic, and then I would like to give her hormones of which I definitely know that they are good for the bone. And as long as we do not have long-term data on estetrol addressing bone health, I would probably prefer estradiol for this group of women.
But Professor Stute, don't you give transdermal then?
Yes, that's
Estradiol.
perfect. Yes, that's the perfect route, of course.
Mm.
But if a woman doesn't want to take transdermal estradiol, then of course I have to give her anything. And then my favorite would be oral estradiol, and I would be a little bit cautious at the moment with estetrol, but maybe this changes in a few years.
I think we have another question for Professor Stute. The Margot Lemay is asking, are there studies on bleeding profile or combined hormonal contraception versus the progestin-only oral contraception, but with a continued use of the COC without the 7-day pill-free interval?
To be honest, I haven't found one. Because maybe you know better, but I was wondering if first of all, we do not have so many pills that have a official long-term regimen. So I'm wondering who's going to do a study with off-label use of a COC and then compare it to a POP. So that's probably a little bit difficult to get it through the ethical committee. So that was my thought about it, but maybe you know more studies and maybe there is a comparison, head-to-head comparison.
I actually do not any study of this kind, and you're completely right that ethical committee would not allow this. Then we have
what would be really interesting also is to perform a study with the combined hormonal contraceptive and compare it to a POP with a break.
Yes.
And see the bleeding patterns.
Yeah.
If they are much different, really.
Yeah. Then we have two questions on estetrol and breast tissue. There is Jasreed Joshi was asking if Professor Simoncini could explain better the effect on breast tissue. And the second question from the same person is whether we can give the estetrol to someone who had breast cancer, but I think that you can give the answer, Professor Simoncini.
Yeah, sure. I'll start right away. So let me start by saying that estetrol works on breast tissue in complex ways, slightly different from estradiol. So it depends on the system because there's more, so far, of course, information on the isolated cell culture, so laboratory settings or animals. But in both cases, it looks like that if you give estetrol, it does not reduce the proliferation of breast cells as much as it does natural estradiol or natural estradiol, because that's been the comparator. And if you provide estetrol together with estradiol, estetrol tends to block the proliferation induced by estradiol. So again, this nest concept that has specific effects that depending on the tissue is found derives from this preclinical investigation. Can it be given to a breast cancer patient? No, there's a formal contraindication. But to be sincere, there have been studies in women with breast cancer. Some of these have been published with high doses of estetrol. So it's a slightly different setting. I don't want to confound the ideas on this specific combination. But these studies have shown that if a woman has a breast cancer, particularly there has been a study published in Vienna, which shows that women with breast cancer undergoing surgery, if you provide estetrol for 2 weeks, the number of mitosis in breast cancer cells when the tumor is taken off are lower than in patients that did not receive estetrol. So, and there are investigations undergoing to use estetrol to treat, for instance, vasomotor symptoms in patients with breast cancer that has shown some interesting information. So the short answer is no, you should not use these contraceptives in breast cancer patients, but there's reason to think that there might be applications in the future when these have been appropriately investigated. So who knows for the future?
I think it's absolutely correct that we don't have to forget that there are contraindications to estrogen use, whether they are natural or synthetic like ethylene estradiol, but we must keep in mind that. And there is another question, whether we should use, or the estetrol combination should become the pill of choice in women who are on enzyme-inducing drugs.
Well, if it's for me, I would say absolutely yes. So the information we have so far is that you know, the estrogen that impacts less cytochrome P450 enzymes is estetrol. So it would certainly be a reason to choose this type of. And in my personal practice, I tend to have these. Use of drugs that impact on cytochrome P450 as a reason to choose this type of contraceptive. So yes, I think so.
And then we have a question for Professor Petra Stute, because I think that the theme of the athletes is something really, really important. And the question is, do you know whether there is any knowledge about the effect of the association estradiol-dose-pyrenol on performance among athletes? I have heard that performance differs during natural menstrual cycle and the use of combined hormones contraceptive.
Of course, we do not have the answer for this question because we have just got the new contraceptive pill. So there's no special study in athletes. However, I would guess that if in the moment you take a combined hormonal contraception, you do not have your cycle anymore. So if you want to do, work out or do your training depending on your menstrual cycle, this will not be possible regardless which COC you are using. And I'm not so sure, for example, if you take, but that's not clear from the research, if you take a combined oral contraception, I would actually personally prefer a testosterone derivative for if you are an athlete, because then I would guess that at least even if you suppress your androgens, you at least have a progestin with a testosterone component. So that would be my preference in this case.
If they want a COC. If they want to combine hormone
if they want a
contraceptive.
COC.
Otherwise, there are better suggestions for these patients.
You're right.
And then there is a question on the use of the injectable Depo-Provera to reduce climateric symptoms, which I think we can forward to the Doc Matter community, so we can open a new discussion on that. What do you think, Helena?
I can also say something about this.
Okay, perfect.
Yeah. So I know that if you go through the literature and you read about what can you do if estrogens are contraindicated due to certain reasons in menopausal women, then you usually read that progestin DMPA is one option to reduce menopausal hot flushes. But on the other hand, we know that DMPA has a negative impact on bone health, especially in this group of women. And also, even if you took it as a contraception method, then it's a relative contraindication if you have any kind of cardiovascular risk factors. So this means in women that are menopausal, they tend to have some cardiovascular risk factors. And then if you also know that it's not good for bone health, I wouldn't take it. And we have so many other options for menopausal symptoms. So I wouldn't pick DMPA for that.
I do agree with that, but we can also open the discussion as well, because maybe there are a lot of other doctors who wants to have something to say on that.
I don't understand the physiological mechanism by which it would work. It would probably just be like a general calming effect, a sedative effect or something.
Yeah,
or
something like that.
What would be the physiological, the receptor function behind?
But I think usually you can use progesterone, at least, to treat menopausal symptoms. So there's one placebo-controlled trial with progesterone 300 milligram per day, and it significantly reduces hot flushes. So it probably also has an impact on the candy neurons in your hypothalamus. And the idea with DMPA is really quite old. I think these are old studies that have shown that you can reduce hot flushes with DMPA. But as I said, it's for me, the risk would be, I would just prefer other products that are also more efficient and safer than DMPA in perimenopausal or menopausal women.
Well, actually, the risk of fracture is higher, so I would not suggest to use the DMPA as well. I wouldn't use it in the youngest girls. And probably the progesterone should have a function on the GABAergic system. So probably it's that one that will work. So I think that we don't have any other question. I think we can go on thanking all the participants who were really high during the webinar, and to thank, of course, the speakers and my co-moderator, Helena Kopp Kalner. And I will share my screen. Okay. So thank you really for having participated in today's webinar, and thank you also to Gideon Richter for his contribution for consenting to have this webinar done. Thank you very much, everybody.
Thank you too.
Thank you very much.
Thank you.